Well, my name is Robert Gillespie. I'd like to thank the San Diego Shoulder Institute and the organizers for having me as part of this webinar, where we're discussing the ABCs and the five Ps of total shoulder replacement in the ambulatory surgery center. So I've been tasked with debating one of my good friends, Serena, on the outpatient shoulder replacement in the hospital setting. So this is something that we've been doing for a really long time. So without further ado, I do have some disclosures. They're all on the Academy website. So just for a brief outline, we're going to talk about the history of outpatient shoulder replacement, a little bit that's already been covered, why we had the initial move to doing outpatient shoulder replacement, what we did to optimize it, and why do we keep doing it. And I'm going to be competing against this good-looking guy who clearly probably already has made the arguments for why we should be doing this at the ambulatory surgery center. And I'm going to try to make some arguments for why we do it in the hospital setting, which I think is critical for a lot of reasons that I hope to tell you guys about during this talk. So we all know that shoulder arthroplasty is on the rise. I think that's one of the biggest things. Shoulder replacement is rising at rates that are much higher than total knee and total hip replacement. So we need a place to do them. We need an efficient way to do them. We need a cost-effective way to get the best patient outcomes. And I think that's critical. So as we see this rise, we need to get better at the process that goes on in order to have our patients get the best outcome. And we know from Quinn and from a lot of others that we've been able to negotiate very safely, figuring out a way to do outpatient shoulder replacement. It really gained some steam. Quinn and Ty down in Tennessee really showed us that this was something that was very doable. When we were first into practice, everyone stayed. Yeah, and when I was a resident, people would stay a couple of days for their shoulder replacement. They'd have drains, they'd have all these things. And now we've progressed very quickly to these kind of things. And a lot of the modalities we'll talk about have allowed us to do that. And we've even gotten to the point you can see here, the Duke group has talked to us actually having outpatient revision shoulder replacements, which can be an interesting thing as well that we can talk a little bit about. So when we're thinking about some of this stuff, some of this is driven a little bit by the government. There has been a shift for the total shoulder replacements to be more an outpatient bill. It's come off the inpatient only list, I believe, in about 2021. And you can see here, if you do an inpatient shoulder replacement in a hospital setting, you can make a slightly more money, but it's a lot bigger hill to climb to get that reimbursement. And as you can see here, they've decreased the reimbursement for outpatient shoulder replacement. So we have to figure out ways of doing it efficiently, cost effective, and again, good for the patients. So when did we start doing this? Well, in 2017, we started looking at this. Our total joints colleagues at our university hospitals in Cleveland started doing outpatient knee and hip replacement. So we started doing this. We had initial criteria. We really followed what Quinn had, less than 75. They had to have some home assistance and it had to be a primary, as well as the medical comorbidities had to be fairly low. Our readmission rate was really good, less than 1%. They got antibiotics and saw a PT occupational therapist before they went home, and we were amazed at how well they did. And a lot of this was based on the fact that when we used to round on our patients on post-op day one, they'd just be sitting there eating their breakfast, drinking coffee, and having no problems. So why wouldn't we send them home? And Quinn's studies and other studies that have been very consistent, we've been able to reproduce that. And then COVID happened, and then everything changed in my world because it went from having fairly strict criteria for our patients to go home the same day of surgery from our hospital to now almost everyone went home. We had 93-year-olds that were going home. We would talk to them about with their family and other things. And so it really opened our eyes. Maybe one benefit of COVID was it opened our eyes to the fact that maybe we could really broaden our indications for our patients to go home on. An advantage in the hospital was that if, God forbid, you needed to stay, then you had a place to stay that would be well equipped for getting your disposition correct. So Medicare reimbursement also sort of played a role in this. In 2021, it came off the IPO list. And so, again, we had to start thinking more and more about how to consolidate those costs. There was an incentive to move it to the outpatient ambulatory center. Even if it was within the hospitals wanted us to do that, find an efficient way of not admitting the patients, not taking up beds in the hospital, and not increasing our risk and exposing our patients to possible infections and nosocomial infections that they would get by being in the hospital. So then what was our current algorithm? Again, we do this all in the hospital setting. We do not go to the ambulatory surgery center. These are all in 300 to 400 bed hospitals that we're doing our outpatient shoulder replacement. So my inclusion is really any patient that needs a total shoulder. And my only absolute contraindications for people who are going to go home the same day are those that need to use their arm to weight bear. Very rarely we have a social support issue where they don't have family that can help them for the first day or so. And age really is no longer a factor. So I could see anybody's grandmother, and if they're cleared, medically optimized by their primary care doc and by our PATs, there's no reason why they can't go home. They could have a cardiac history, pulmonary history, and that's really one of the big takeaway points. So why not in the hospital? Why wouldn't you do this? Well, this is from our good friend Larry Galata, who talks about complications of shoulder replacement. And this video is a really fun video that he showed. And why, if you're not in the hospital and you get into one of these complications that we can in the shoulder replacement, because we're very close to the vessels, this is something that I would say, even though it happens very, very, very rarely, this is another reason that you should think about doing outpatient shoulder replacement in a hospital setting. You'll have vascular surgery potentially available. You have other resources available, blood products, things like that. Probably even have better anesthesiologists that can help you if you run into complications. So that's our number one big reason why we continue to do our outpatient shoulder replacement in the hospital setting. I think there's also something to be said for patient comfort and satisfaction. I have a lot of older patients. They seem to think that coming to a hospital is going to be a better thing, even if they go home the same day. And if things go bad, whether it's anesthesia, nausea, or they don't clear PT or OT, there's somewhere for them to stay that's equipped for that. It's not just they're not just staying behind a curtain at an ambulatory surgery center. They are actually in a hospital being cared for by registered nurses who know how to take care of them and then get them going home the next day, or God forbid, if they need a skilled nursing facility. So what's our current regimen, and how do we allow these patients to get home? Well, it's very similar to other people do. We do a general anesthesia with a single shot block. We have a really low cost of implants and trays. Again, our direct costs and our indirect costs are playing a large role in what we're trying to do with outpatient shoulder replacement. It's good for the patient for sure, but then also the hospitals are going to need to be able to make it a meaningful surgery. So we've really worked on vendor consolidation and tray consolidation. Every single one of our patients gets PT, OT on the day of surgery, either before or after, depending on the time of day they're having their surgery. We have a multimodal pain medication regimen. We love Toradol if their kidneys are good. We try to stay away from the narcotics, but again, we do have narcotics at breakthrough. I do think cold therapy is critical. The only calls I ever get from my patients who go home the same day of surgery are those who did not get cold therapy. We do 1 week of oral antibiotics after a single dose of IV antibiotics. We used to give them an extra dose of IV antibiotics, and that just didn't seem to be cost effective or make sense. And so we have switched to that. And we do give them one dose of tranexamic acid preoperatively. Our hospital very nicely showed years ago that tranexamic acid was very effective at decreasing hematomas and blood loss after total shoulder replacement. And so we still believe in that today. So what's next here? Well, we want to continue to work on decreasing direct costs in the hospital setting. If you look at the hospital setting versus the ambulatory surgery center, you can't just take the actual reimbursement, which you get in a hospital setting for an outpatient surgery and translate to an ambulatory surgery center. That those are going to be, in theory, we can be more cost effective than the ambulatory surgery center, but that could be very much of a loss leader. So in the hospital setting, we know what our reimbursement is going to be for the outpatient shoulder replacement. So we're going to continue to work on trade consolidation, vendor consolidation, disposable timeouts. We're going to partner with the hospital to optimize those indirect costs, those things that we don't really have a direct effect on. And we're going to explore opportunities that enhance patient experience, but do not compromise our patient outcomes. And that's critical. So in summary, I would say the outpatient total shoulder replacement is safe and effective. Quinn and everyone on this call has shown that very clearly. Programs can be set up in an ASC or a hospital setting. I think either are great. I do prefer the hospital setting, and you'll see why here in a second. Hospital setting may allow for a more aggressive algorithm than patient selection. I don't have to think about whether my patients are going to go home or not. I tell them that they're all going to go home. And if they can't go home, we're already in that setting, which would be well equipped to deal with that. So there's no decision on whether this patient's going to get their surgery in ASC or this patient's going to get their surgery in the hospital. They're all going to get their surgery at the same two hospitals that I operate with, and we don't have to think about it. It makes it much easier for my team. It makes it much easier for anesthesia. I do believe that the hospital setting is better at handling the very rare but catastrophic complications that we talked about. And I do think this is just, again, easier for our team to schedule. Everyone goes home. 90% of our patients go home, but if you don't go home, we have a place for you, and it's much more better equipped than a small ambulatory surgery center to take care of you for that 23 to 72 hours that you may require after surgery. I'd like to thank the San Diego Shoulder Institute again for giving me the opportunity to be a part of this webinar, and I'm looking forward to hearing more about the questions and answers in a little bit. Thank you again.